Well, good evening, everyone, and welcome. Thank you for joining us this evening for this very important and timely webinar and panel discussion on COVID and health. I'm Kira Parrott, Director of Darien Library, and I am so grateful for the town of Darien and Stanford Health who are sponsoring this evening's event. Just a quick note for our virtual audience, this is a Zoom webinar. So that means you can hear and you can see the panelists and the presenters, but we can't hear or see you. So you don't have to worry about your webcam or mic being on for this type of event. Although we do encourage you to submit questions for the panelists this evening using the Q&A button, which you can find on the bottom of your screen. And you can submit questions at any time. And I believe our moderator is going to have some time at the end of the program to address those questions. And with that, I would like to welcome Darien's first selectman, Jamie Stevenson. Good evening, Jamie. Thank you so much for being here tonight.
Good evening, and thank you so much, Kira. Really thrilled to partner with the library and Stanford Health this evening. I'm Jamie Stevenson. It's been my privilege to serve as first selectman to the town of Darien for the past 10 years. In that role, there's nothing more important than the caring for the health and well-being of our friends and neighbors and citizens of Darien. The purpose of this event is to provide information about why it's important for you and your family to resume healthcare. Many have put off healthcare during the pandemic, and we have experts with us this evening to explain why we should resume our routine exams and screenings. I can promise you that you will receive a wealth of interesting and even better reliable information during this session. Our thanks goes to Stanford Health, co-sponsor with the town of Darien for tonight's update, and to our friends at the Darien Library for serving as hosts. It's wonderful that we may be finally nearing the end of the pandemic, and that's held us in the grip for more than a year. Every day, there are very hopeful signs. More and more of our fellow citizens are vaccinated, treatments are more successful, so cases are usually less severe. However, we must continue to abide by the guidelines. Now is no time to let down our guard. Yet we can finally start to think about what life after COVID-19 might be like. I'd like to introduce Darien's Director of Public Health, David Knoff, to give us a quick update with respect to COVID-19 and vaccines here in Darien. Good evening, David.
Good evening, Jamie. Thank you, and thank you, Kira, Library, at the library, and also Stanford Health. Just a basic overview of what we've been seeing is that since the pandemic began last March, we have had just under 1,500 cases in Darien. To meet that challenge, since the vaccines have become available, we have held 27 clinics in town and vaccinated. We've done 5,000 vaccination doses have been given, and fully vaccinated just about 2,500 people. According to the state database, we're not the only source of vaccine in town. And according to the state database, the town of Darien's rate of vaccination is over 50% and closing in on 70% total population being vaccinated, and that's over 16. So we're doing really well in the community in terms of reaching people and getting people vaccinated. As we all know, the Johnson & Johnson vaccine is on pause. We had been using that, but we're not going to be issuing any Johnson & Johnson until we get clearance from the State Health Department and CDC. But there haven't been any reported health problems or reactions associated with that in Connecticut. So I'm pleased to report that. With that, I'll turn it back to you, Jamie. That's
Great.
our update.
Thank you so much, David, and thank you to you and your staff and all of the volunteers that have worked tirelessly to put together an incredible vaccine clinic for the town of Darien. Before I introduce our distinguished guests, as a housekeeping note, I want to let you know that our panelists will speak for about 40 minutes, and then we'll have a question and answer session. Laura Jordan of Stanford Health will moderate the Q&A. You can ask a question by using the chat feature or by raising your hand at the end of the presentation. The pandemic has had a terrible impact on the world. In addition to the staggering death toll, now more than 530,000 Americans, nearing 3 million worldwide, we have seen immense economic suffering, delays in children's education, spikes in mental health issues, and many other effects. There's hidden damage from COVID-19 as well. For far too many of us, we've postponed, delayed, or gone without basic health care for the past 12 months. We've not felt safe going for checkups, obtaining tests, or attending to chronic health conditions. One result is that the diagnosis of serious disease besides COVID-19 have gone down a lot. Weekly reports on 6 types of cancer, for example, are down 46%. This is not good news. It's clear that people are simply not getting the screenings they need, screenings and tests for heart disease, cancer, and other serious conditions provide a valuable early warning. The sooner these diseases are identified, the sooner they can be treated. The delays and postponements caused by COVID-19 mean that many people are not getting that early warning. When they do find out they're ill, they're likely to be sicker and harder to treat. Valuable time will be lost, and extraordinary pressure will be put upon hospitals still recovering from multiple waves of the pandemic. This is why we have entitled this session, Care Makes a Comeback. We're asking all of the citizens of Darien not to delay your health care any longer. If you've been holding off on seeing your doctor, either for routine checkups or particular concerns, don't wait. If you've not been getting regular screenings for heart, blood pressure, cancer, or other life-saving measures, please do so. Our friends and co-sponsors at Stanford Health are fully open and able to accommodate you for preventative, emergency, and routine health matters. In addition to Stanford Hospital, a U.S. News and World Report high-performing hospital for 2020-2021, Stanford Health has locations throughout Fairfield County, including right here in Darien. With sophisticated clinical services in cardiovascular disease, orthopedics, cancer, neurology, women's health, and other specialties, and multidisciplinary centers, imaging, rehabilitation, walk-in, and urgent care, along with more than 40 medical offices, Stanford Health can meet any health and wellness need. Tonight, the town of Darien, the Darien Library, and Stanford Health are happy to bring to you 3 true experts in the comeback of care. Dr. Shaw is Associate Director of Infectious Diseases. She's been instrumental in the pandemic response at Stanford Health and will give us a complete update on the vaccines, the variants, and what you can do to keep your family and community as safe as possible. Dr. Falahi is an interventional cardiologist at Stanford Health. He will talk about the importance of regular heart health screenings and the latest information on cardiovascular health. And Dr. Del Preti is head of clinical trials at the Bennett Cancer Center at Stanford Health. He'll bring us up to date on the most advanced immunotherapies and Stanford Health's expanded partnership with Dana-Farber, Brigham and Williams Cancer Center. After our experts finish their presentations, there will be lots of time for you to ask your questions. My deep thanks to Dr. Shaw, Dr. Falahi, and Dr. Del Preti, as well as Stanford Health, and our hosts, the Darien Library. And now please welcome Dr. Asha Shah.
Thanks, Jamie. And thanks for having me tonight as a resident of Darien for the past almost 7 years. This talk tonight is even that much more meaningful to me. So I'm just basically, my goal tonight is to give everyone an update of where we stand in terms of COVID, nationally, locally, talk a little bit about the variants, and then really focus on the vaccines. So just to give everyone a sense of where we stand in the United States. This is the total number of new cases by day over the course of the last over a year, since March of 2020, when the pandemic began. And what I think is so notable about this epidemiologic curve is that, you know, what we experienced most recently here in the United States in the fall and winter makes what we experienced in the spring in terms of numbers seem a little bit insignificant. And you can argue that that was due to a lack of testing and lack of detection of COVID. But you can see that there's been kind of 3 waves of COVID throughout the, you know, nationally. And, you know, cases seem to be leveling off a bit over the past several weeks, going a little bit up, but not really trending, you know, terribly too high. And I think what's most notable is that we're seeing a divergence in cases and deaths. And that is something that we will continue to anticipate to see as the vaccine uptake increases across the country. And you can see that here. This is national data, again, looking at our new reported deaths by day in the top graph and hospitalized patients in the bottom. And again, it's really nice to see that the number of new reported deaths continues to decline and our hospitalizations are leveling off nationally. In terms of our Connecticut data, this is obtained from the Connecticut Department of Health. Our positivity rate runs at about 3%, or 3 to 3.5%. It's been there for the past several weeks. And we're seeing similar rates in Stamford. And again, this is the similar epidemiologic curve, but just for Connecticut. We had a nice summer after the spring surge of 2020. And again, this second curve represents what we just experienced in the winter, and things seem to be leveling off, which is a good and optimistic sign. And what's most notable is, you know, who's getting COVID now in the state. And this graph represents the percentages of cases by age group. And what you can see here is that it's the younger people that are getting COVID, and it's those that are unvaccinated. Of course, vaccine eligibility opened for all on April 1st. So this is to be expected, but it's nice to see that our elderly, more vulnerable population are getting infected less. And we hope this trend continues through all the age groups as vaccines continue to be distributed. In terms of our hospitalizations in the state, that's what's represented in this left graph here. The different colored lines represent the different counties. Fairfield County is in this blue line here. So again, hospitalizations across the state are leveling off. And what we've been saying over the past couple of weeks, everything is stable. It's not going up, it's not going down. Things have just kind of leveled off in terms of hospitalizations. And again, nice to see our deaths, our number of deaths going down nicely across the state as vaccines continue to be given. And, you know, kind of a fallout of the pandemic and our response, I think is what was very interesting is what we've seen with the flu. And so this graph represents our internal data from Stanford Hospital that we tabulate every week. The purple line represents our COVID cases, and the green line represents our flu cases. And we look at our flu data every year in and year out. And this date goes back to December of 2019. And as soon as the public health measures were put into place in the spring of 2020, we saw no flu. And as you can see here, you know, COVID had a wild party, but the flu line has flatlined. And that's further depicted here. This is looking at our total number of flu cases and RSV cases, which is another type of respiratory virus that we commonly see every winter, mostly if it infects children. We've seen a total of 2 cases of flu and 2 RSV over the entire 2020 to 2021 flu season. So, you know, the masking and the social distancing and the hand hygiene really work phenomenally well for other respiratory viruses, but unfortunately, you know, didn't do the trick for COVID, which is why we need the vaccines. So in terms of variants, that's another big kind of question, and people, seem to be concerned about this. So in terms of where we stand in Connecticut, the left graph here looks at the percentage of our percentage of isolates that are represented by the variants. And as you can see, back in December 2020, we weren't seeing much in terms of variants. And so what we were seeing mostly was the wild type COVID. And that's a term that we use to describe the original COVID that we've dealt with last spring and up until now. And what you can see in February and January is this creep of the B117 strain that's now become more prevalent in our state. And that's represented by the red shade here. The B1526 strain is actually the New York strain, and that is represented by the blue area here. What's important to note about the New York strain is that it's not a variant of a concern. It's actually a variant of interest, and it doesn't seem to have much impact in terms of our vaccines and our therapeutics. But obviously, the UK strain is something that we're watching more closely. And the rise in the UK strain in our state is depicted here on this graph with this purple line really shooting up here in February and March, and that represents the percentage of isolates that are the UK strain. So as of April 8th, so last week, about 40% of the COVID isolates that were circulating in Connecticut that were being tested were found to be the UK strain. And what we know about this strain is that there is a potential for increased transmission. It can be up to 70% more transmissible, which is obviously concerning. There's a slight increase in severity of disease, although the jury seems to be out about that. But you can argue that if more people are going to be infected, there's a likelihood that a vulnerable person would be infected and possibly end up hospitalized or very ill from COVID. And what the promising news about the B117 strain is that our vaccines are effective against the strain, as are our therapeutics. Another strain that we're watching very closely is the South African variant, which is the B1.351 strain. Very small percentage in the state, 0.5% of isolates as of last week. Also increased transmission and some moderate resistance actually to some of our COVID therapeutics. And that's something that we've had to take note of when we're making our treatment plans at the hospital, but seem to have minimal resistance to our vaccines. And so in terms of, the question, do the vaccines work against these variants? Do I need to be concerned? And I think that's depicted most effectively by this New England Journal of Medicine article that looked at nationwide mass vaccination in Israel. And what these graphs show is that individuals in Israel who were vaccinated with the Pfizer vaccine, they're represented by the blue line. They had decreased incidence of COVID infection, whether symptomatic or asymptomatic, decreased incidence of severe COVID, decreased incidence of hospitalization due to COVID, and decreased death due to COVID. And during that study period, 80% of the circulating strains in Israel were the B117 strain. So this to us, it is promising that, everything will be okay if we, vaccinate quickly enough in the state, and it will work against this UK strain. So, speaking of vaccines, so this is the COVID-19 vaccine tracker from the New York Times. And so we have 3 vaccines that have an emergency use authorization in the United States, obviously the Pfizer, the Moderna, and the Johnson & Johnson. And if you compare the 3 vaccines head to head, and this is a chart that I made to look at all of the trials and to try to compare the 3 vaccines. And so first off, all of the vaccine trials had a lot of participants, right? And that's something that you want in a research trial, to look at the efficacy of a vaccine, well over 30, 40,000 individuals, and a nice breakdown in terms of gender, minority representation, people with other medical problems, individuals above the age of 65. And what's important to note about the Johnson & Johnson trials is that only 44% of enrollment in that trial was in the United States. And so there are variations in terms of geography in that trial, which may account for some of the differences in the efficacy that we're seeing. Most importantly, all 3 vaccines were found to prevent death or hospitalization due to COVID, and effectiveness overall were close to 95% for the Pfizer and the Moderna vaccine, and 85% for the Johnson & Johnson vaccine, and serious adverse events, in very low percentages across all 3 trials. So again, about the Johnson & Johnson vaccine, was a significant difference in the vaccine trials in time and geography. The Pfizer and Moderna trials were really conducted last summer, when all we were seeing was wild type, the original COVID. When the Johnson & Johnson vaccine was going on, there were all these variants circulating. And if you actually extract the data from the Janssen trial, the Johnson & Johnson vaccine is actually 92% effective for individuals ages 18 to 60. So in younger individuals, it was actually found to be more efficacious and similar to what was seen with the mRNA vaccines. A second dose Janssen study is underway. So if a 2-dose regimen is superior to a 1-dose regimen, then a booster can be given later. So obviously, I'd be remiss if I don't talk about what happened yesterday. David Knoff mentioned this earlier, but as of yesterday, as many of you know, the administration of the J&J vaccine was paused per guidance from the CDC and the FDA. And this is due to reports of severe thrombocytopenia and blood clots. And thrombocytopenia is a term that refers to a low level of platelets in the blood. And this occurred within 6 to 14 days of administration of the vaccine. And the individuals who developed this adverse effect, they were ages 18 to 48. 80% of them were female, and the blood clots were seen in the brain as well as in the vessels that drain the digestive system. There was no association found with oral contraceptive drugs. I know that was a big question. And the symptoms that we're seeing, what we would look out for are severe headache, abdominal pain, leg pain and swelling, shortness of breath, a type of rash on your lower extremities, occurring really 1 to 2 weeks after vaccination. The most important point is that these events are exceedingly rare. So it was only 6 individuals in the nearly 7 million doses that have been administered so far. So less than 1 in a million chance that this is to occur. And similar findings were seen with the AstraZeneca vaccine. So there's been some questions and some postings today on all of our listservers, whether it's the adenovirus component of these vaccines that elicited this type of response, and it's possibly an autoimmune phenomenon. So very, very low numbers, and the pause was put into place out of an abundance of caution, mostly so that all of the physicians and providers across the country became aware of this situation and what to look out for in case someone were to come down with a case. And the ACIP met today to kind of discuss what the next steps would be. But the anticipation is that the pause will be lifted. I don't know how long, but that this is not something that's going to take this vaccine off the market. So in terms of what's happened in Connecticut, as was mentioned earlier, roughly 100,000 Connecticut residents have received the J&J vaccine. There have been no reported serious adverse events in the state, as David mentioned early on. The Stanford Hospital, City of Stanford vaccine clinics have administered just under 1,700 doses of the J&J vaccine. No serious adverse events reported to our knowledge. So individuals who have an upcoming appointment scheduled to receive the J&J vaccine will be offered an alternate product, so either the Pfizer or the Moderna vaccine, or be rescheduled if that's what the wish is. Our current supply of J&J vaccine is limited to begin with, so the pause, thankfully, actually will not impact any of our operations at our mass vaccine clinics. And it's important to know, and an important message I want to send is that the J&J vaccine is a good vaccine. It's effective in preventing severe disease and hospitalization and death. It's logistically easier to administer because it's a single dose. It's very ideal for mobile clinics, door-to-door outreach, people who may have difficulty returning for a second dose. And so I don't want people to lose faith in this vaccine. And we await additional guidance from the CDC and the FDA after further deliberation. So the bottom line is all 3 vaccines are good. And full vaccination is highly effective against both the UK and the South African variants. And whatever vaccine is offered to you, get it. There's no best vaccine. And so just a couple slides to show you how well the vaccine has worked in the real world, because we really dissected the original vaccine trials, but how well has it worked now that the vaccine's been given for about 4 months? So this was an article that was published in the MMWR that looked at healthcare worker vaccinations, and a fair number of healthcare workers, over 200,000. And what they found was that the vaccine effectiveness was 91% in preventing infection by COVID. And even more striking was this data out of UT Southwestern, which looked at employees there who received either their first or second dose of vaccine. And what they found is that 0.05% of fully vaccinated employees developed COVID, compared to 2.61% who were not vaccinated. So only 4 out of 8,000 employees that were fully vaccinated got COVID, as opposed to 234 that did not get vaccinated. So very, very good real world data that these vaccines work. And they also showed that the number of positive tests amongst employees was consistently lower than what was projected based on their community prevalence of COVID, which they measured by patients coming into the ER. And they found that those who were vaccinated were even further protected. So another burning question is, how long will the vaccine last? How long am I protected? Do I have to get vaccinated every year? So we still don't know. But this is data from one of our infectious disease journals, and the top graph essentially represents antibody responses after having COVID. So that's the antibody response that people get when they're infected with COVID. And what you can see is this gray line falls, right? Over a period of months, this antibody response, it becomes less protective. The bottom here represents the antibody response after vaccination. And it's a nice straight line at the top of the graph, which shows that there's really durable immunity. And so the immunity is likely 6 months, at least 6 months, but it's likely much longer than that. And we're still learning about when and what time period would go by before we need boosters, if we need them at all. So you're fully vaccinated, right? So what do you do? So what we do know is that fully vaccinated people are less likely to get sick from COVID. They're less likely to have asymptomatic COVID infection, and they're potentially less likely to transmit it to others. And that's why the CDC says that if you're fully vaccinated, you can spend time with one another indoors with other fully vaccinated individuals without masks, without social distancing, so you can hug your friends that you haven't hugged in over a year if you're all fully vaccinated. You don't have to test or quarantine after direct exposure to COVID if you remain symptom-free. And you don't have to test or quarantine after domestic travel if you're fully vaccinated. And again, fully vaccinated means it's been 2 weeks since completion of your COVID vaccination. Regardless of vaccination status, it's still important to perform rigorous hand hygiene, masking, social distancing when you're in public, right? Because we don't know what everyone's vaccination status is. If you feel sick, stay home, get tested. There are breakthrough cases of COVID, and we've seen, a small number of them, but it's still possible. And so you want to be diligent about not going around if you're sick. And following CDC travel guidance, I think, is very important, especially as we go into spring breaks and summer. It's important to follow that guidance, whether you're vaccinated or not. In terms of what's going on in children, I know this is a big question amongst my peers and other individuals who have young children. So the Pfizer vaccine trials for ages 12 and above enrolled over 2,200 participants, and the vaccine efficacy was found to be 100%, which was amazing. Nothing's 100% in medicine. This has been sent to the FDA for a review, and we're anticipating a response, hopefully within the next several weeks, which is great news. The Moderna is also looking at trials, is also enrolling 12 and above. There's 3,000 participants in that trial so far. And then there's the KidCove trial that's looking at ages 6 months to 12 years. Varying doses are being studied and similar for the Johnson & Johnson vaccine. So bottom line is 12 and above will probably be able to start vaccinating by the summer, maybe a little even sooner. And 5 and above will hopefully be later this year, end of this year, maybe beginning of 2022. So how are we doing at vaccination across the state? This is a graph that shows the weekly total of number of vaccinations given, and kudos to the state and the leadership at the state level. You can see this nice ramp up of vaccines given starting in December of 2020 when all the healthcare workers were starting to get vaccinated. We have 41% of the total population that have received at least one dose of vaccine, and 25.8% fully vaccinated. This may be a little outdated because this was data as of last week. This is also data from last week, which showing vaccination coverage by age group. And what's nice to see again is these 65 and above getting up there in the 80% of at least one dose administered. But now we're starting to see higher numbers in our younger folks as well. And we hope that this continues. So just to end, Stanford Health has partnered with the city of Stanford to develop a community vaccine program for phase 1B, which began in January. We give vaccines at the main hospital as well as at Elmcroft Road and in Stanford. So far, we have given over 84,000 shots, majority of those being Pfizer, 77%, 21% Moderna, and again, a very small percentage, 2% of J&J. This represents 58,000 patients, and 48% are fully vaccinated. And we have 34,000 appointments scheduled in the coming weeks. So to schedule your vaccine, if you haven't already done so, you can go to covidvaccinefinder.ct.gov and you can search for vaccine sites based on your zip code. And you can also schedule through stanfordhealth.org and you click through the prompts and schedule through ZocDoc.
Thank you. We will now turn the program to Dr. Falahi.
All right. So today I'm going to talk about heart disease and COVID. The main topic for today is sort of this delay in care that people get sort of in this COVID era. So understatement of the century, 2020 was really a crazy year. By March and April, hospitals were completely overwhelmed by coronavirus. And I just wanted to give some photographs of sort of what Stanford Hospital was like at the peak of the pandemic, just to sort of put everything in perspective. When you look at the ER board, usually it's a whole milieu of different conditions from abdominal pain, traumas and everything. But in the spring, it was pretty much dominated with fever and shortness of breath. And so we saw this surge of COVID cases come through, and there was not very much testing at the time. It was a very unknown time. People were sort of gowned head to toe. There was a lot of uncertainty. We had an army of nurses, doctors, and staff at the hospital. We nearly tripled our amount of ICU beds from 20 to 60. Really was described as kind of a war scene, and so much so that we actually had the military come and help out with the COVID effort. So it was a really tremendously challenging time for the hospital. And so, as of the beginning of this week, 31 million cases in the United States, over 560 deaths from the spring of 2020. Despite how devastating COVID was, what I wanted to point out is that heart disease in 2020 was still the #1 leading cause of death. Shockingly, COVID was the 3rd leading cause of death. I never thought that any disease would break the top 10, let alone be in the top 3. But it just shows that heart disease is still the leading cause of death by quite a margin. 690,000 deaths in 2020 alone. Coronavirus was around, over 350,000 deaths. Still staggering numbers, but it tells you how prevalent heart disease is. At the height of the pandemic, there was a cancellation of elective procedures. So this was largely to help protect personal protective equipment when there was a shortage of masks and PPE. Also to help create beds and free up staff to man the ICUs. And hospitals in the tri-state area canceled all elective procedures during the peak of the pandemic. And that included my area of expertise, which is interventional cardiology. So elective procedures, cardiac procedures were canceled. When this went into effect, we saw a very alarming trend that emerged. You would expect that in the height of a pandemic with a very severe respiratory illness, that typically heart attacks would go up. If you're stressing the body, the number of patients coming in with heart attacks would be expected to go up. In flu season, we tend to see a little bump in terms of heart attacks. But what we were seeing, surprisingly, was that the number of patients coming in for cardiac emergencies plummeted. And this was not just seen in the United States. There was reports from Spain, Italy, Hong Kong, globally. The cases plummeted, so much so that the New York Times in April had an article asking, where have all the heart attacks gone? And so to sort of try to help answer this question, this is an article out of the New England Journal late last year looking at the California experience. You can look here, March 4th was the first death from COVID. And you can see the blue line is COVID infections. So it vertically went up practically in March. And you can see the yellow line is acute MI, which is myocardial infarction. So these are heart attacks in 2019. And you can see this red line in 2020, and it just drops off dramatically. And this is April 8th to 14th. It continues to decline. So as COVID went up, heart attacks seem to go down. Nationwide, the activations for heart attacks went down. What I mean by activations is if someone has a major heart attack, there's a STEMI activation. So a cardiac cath team assembles to try to get to open up the artery as fast as possible. And those STEMI activations dramatically decreased at the height of the pandemic. And this was seen nationwide. Another very alarming trend that emerged during the pandemic was that out-of-hospital cardiac arrest dramatically increased. In one of the largest healthcare systems in the United States, Northwell, in the New York City area, showed an almost 5-fold increase in cardiac arrest deaths. And at the same time, this was associated with a 50% reduction in admissions for heart attacks. This graph illustrates this rather dramatically. If you look at the blue line here, this is the cardiac arrest deaths in 2019, and this huge spike we see in April. This is almost exactly a year ago. You can see the cardiac arrest deaths just shooting through the roof. Multiple studies confirm this trend. A study of over 5,000 patients in New York City who called emergency medical services showed an over 3-fold increase in cardiac arrest with a dismal survival rate of fatality rate of over 90%. So again, very similar graph you'll see in 2019 versus the COVID period. You see a dramatic spike in the incidence of cardiac arrest. So what was this due to? There was a real fear, and there still is a fear of getting medical care in the COVID era. Patients are very fearful of contracting COVID-19 in the hospital or clinic. As a result, there were patients calling that were terrified. I have chest pain, but I don't want to get COVID. And so symptoms were minimized. They would ignore that chest pain and not come to the hospital. They would ignore that stomach pain. They would ignore that, little blood that they saw in their stool. They would ignore their symptoms. In addition, by not coming into the clinics, there was less or delayed diagnostic testing. And delays in medical care, unfortunately, have really dire consequences. To summarize just the cardiac arrest data in the COVID-19 era, there was a 50% decrease in patients presenting to the hospital with heart attacks, meaning they may have had heart attacks, they just didn't show to the hospital, 50% reduction. The cardiac arrests went up by over 300%, and the fatality rate was 90%. And the sobering reality is that many patients likely died or have become severely debilitated by delays in their care for fear of getting COVID at a medical facility. And we hear this all the time. I'm scared of getting COVID at the hospital. So one thing I really wanted to talk about today was what really do the facts show? What does our experience at Stanford Hospital show? So let's take a look. Let's step back a year from today, a year ago, and look at the worst phase of the pandemic. How many people contracted COVID at the hospital? So in the ICU that I worked at, despite countless hours with patients, and we performed number of procedures on patients in very close proximity and contact, not a single healthcare worker in our ICU contracted COVID while they were at the hospital. And I think that really, to emphasize Asha's last point, that there really is probably no greater testament to masks and PPE working than the experience in the spring of 2020 with such a low level of hospital-acquired infections. People got COVID, but they did not contract it at the hospital. So taking all this together, I really wanted to give some perspective. Perspective is really key here. So despite the devastating effects of COVID-19, heart disease still remains the top killer in the United States by quite a large margin. And there's been studies that have shown that even accounting for COVID-19, the incidence of cardiovascular death was increased during COVID-19, which may be due to a lack of access to healthcare. Unfortunately, a lot of these data are difficult to really narrow down because we had such little testing at the beginning of the pandemic. So you really are at higher risk of dying from underlying undiagnosed heart disease than from COVID-19. So what if you have underlying cardiovascular disease and COVID? There was a large meta-analysis where they looked at almost 50,000 patients, and patients, there was higher severe infection and death in those with cardiovascular disease or risk factors, meaning if you had diabetes, if you had hypertension, if you had underlying heart disease, you were more likely to have a severe infection or death. Interestingly, in this analysis, younger patients had a lower prevalence, obviously, of heart disease, hypertension, diabetes in older patients, but their relative risk of a fatal outcome was higher. So if the younger you are, if you do have one of those cardiovascular risk factors or disease, it was a higher likelihood of getting severe infection or death. Seeing a cardiologist, so put bluntly, statistically, if you're going to die from something, odds are it will be heart disease. It's been the #1 killer as long as I can remember, and probably will continue to be so, unfortunately. It's really better to get evaluated early to help detect any potential disease at an early stage. When you detect diseases at an early stage, it's more easily treatable. Symptoms can often be subtle. A lot of times, people confuse this with normal signs of aging. Getting short of breath and tired is not really a sign of aging, especially if it happens over a relatively short period of time. So that really tends to get people in trouble. Just briefly, cardiology at Stanford Hospital, we have a very comprehensive cardiovascular disease program, both robust cardiology and screening program. For any visit for screening, we do a lipid profile. We have a lot of models that we use to assess cardiovascular risk. We have tools such as non-contrast and also contrast CT to detect coronary artery calcium to define whether or not you have potential blockages in the arteries of your heart, even before the onset of symptoms, so we can adjust your medications. We have a cardio-oncology program to help manage heart disease and cancer patients. Our non-invasive cardiology employs a lot of advanced imaging. We have the latest generation 2D and 3-dimensional echocardiography to really look at the heart and evaluate structural heart disease in a lot of detail, also look at valvular heart disease. We have stress testing to help determine blockages in the arteries of the heart. This can be done with medications or with exercise. We recently purchased an exercise bike for people that can't go on a treadmill, and we're one of the few centers that actually has that. So it's a very good test for valvular heart disease as well as for stress testing in people who can't exercise. We have advanced CT imaging of the coronary arteries to detect coronary anomalies. We also have a robust and growing MRI program to detect a whole host of cardiac diseases. Interventional cardiology, we have a state-of-the-art cath lab really to treat a host of diseases. We can treat very complex coronary disease. We have the ability to do mechanical circulatory support, so Impella, ECMO. These are devices for extremely sick patients headed towards transplant. We're also capable of treating peripheral arterial disease, so we can do a lot of vascular work, anything from the renal arteries to the legs to the feet. Structural heart interventions, that's my specialty. We can replace the aortic valve without open heart surgery with a catheter, and people go home the next day and are able to do normal activities. Congenital heart interventions, so people that were born with a hole in their heart, who have had a stroke or are suffering from consequences of that, such as shortness of breath, we can close that also with transcatheter therapies. Electrophysiology, these are the electricians of the heart. We have a very strong group, arrhythmia monitoring services for people with palpitations or evidence of arrhythmias, device implantation, pacemakers, defibrillators. We were the first hospital in Connecticut to perform the Watchman procedure when it was commercially available. And we have ablation to get rid of various arrhythmias using the latest catheter-based techniques. Cardiac surgery is a growing, robust program. A whole host of surgeries are performed: coronary artery bypass, aneurysm repair, dissections, and valvular heart disease. So in a nutshell, really the conclusion, the main points is that while COVID-19 fundamentally changed our society, and we really have to be vigilant, heart disease still remains a top killer in the United States. And unfortunately, delays in care due to COVID or fear of contracting COVID has resulted in numerous likely preventable deaths. And Stanford Hospital provides a safe and comprehensive environment to get really excellent and comprehensive cardiac care. So I'll hand it off.
Thank you for inviting me to this discussion this evening. I found my first two colleagues talking about cardiac complications and issues related to COVID, and of course, the infectious disease itself as it relates to COVID. Fascinating. I hope everyone has enjoyed it. I'm Dr. Del Preti. I came into the community quite a while ago in 1984, and I came here pretty much because of my interest in clinical trials. The program we have at Stanford Hospital and the Bennett Cancer Center started in 1984. We were involved primarily with the Eastern Cooperative Oncology Group, which is a very large group of multiple institutions in the United States, along with two other major groups. One of them is SWOG, the Southwest Oncology Group. And these are funded by the NCI, and multiple clinical trials are being done. As we have found out all for the last 16, 17 months, research is a key to every field in medicine, and it certainly was a key in bringing us better therapeutics and better clear-cut vaccination advantages that could not have been done without the clinical trials, and kudos to the people who did the trials and to the patients who actually went on them. But in cancer medicine, that was particularly true as well, and it's been true for the last 4 decades. Our research program at Stanford Hospital, Bennett Cancer Center, became fully staffed back in 1985, before the Bennett Cancer Center existed, and when St. Joe's was still a hospital here. Tully Center now sits on that site, as many of you in the community know. And we frequently have led the state in accruing patients to clinical research studies, because I have always felt that clinical trials is the way of the future. One of my colleagues at Yale back in the mid 80s and early 90s was Dr. Bill Haidt, who said, if we do not put patients on trials now, do not be surprised that in 10 years we are still using the same drugs that we currently use today with the same dismal outcomes. And in 1984, the outcomes were indeed dismal. Prior to that, Dr. DeVita did a landmark study, which was in Hodgkin's disease, where we found that if you threw 4 different drugs together, you can miraculously cure about 70–75% of patients with Hodgkin's disease. Patients with Hodgkin's disease before that died very rapidly. So he did that, and for the next 20 years, oncologists were looking for the next alphabet soup. MOP is 4 drugs. Then we came up with the term CHOP, which is a treatment for non-Hodgkin's lymphoma. But we really never found something as dramatically different looking for chemotherapy in treating cancer as we did with MOP. So doctors were very frustrated, but our basic science colleagues kept pushing the bar higher. And in doing so, as you can see on this slide, the death rate has dropped substantially from 1975 to 2018, where we have data for anyway. The lung cancer death rate actually has dropped significantly as well. 5-year survival has gone up dramatically over the past several years. And it was all because of the research that was being done around the world, really. Here's another slide to depict the changes in the survival. Now, for some people, especially in, I guess, 90%, 95% effectiveness of the COVID vaccines, this doesn't look that exciting. But there were over 200 people dying here per 100,000. Now in 2018, we're down to around 149. That's a fairly big shift. And you can see in the mid 90s, that's when we started to make the inroads. And it's all because of clinical trials and our marriage to the molecular people at the NCI. We found that the best way to approach oncology wasn't really disease oriented. And I'm going to use this trial in lung cancer as an example of what I mean by that. But basically, take lung cancer back in 1980, 85, we were talking about 2 different types of lung cancer: small cell, non-small cell. Patients with lung cancer had one or the other. So people would treat those lung cancers, and we had to treat them differently because they were truly biologically different with different types of chemotherapy. The net result, though, was that most of them died. We kept doing that with different combinations of drugs until our colleagues in the hematology world found out that a very deadly leukemia called CML, chronic myelogenous leukemia, which had a gene defect, a 922 translocation, that could be targeted by a drug called Gleevec. That changed everything. I mean, it really changed the entire scope of oncology. Patients who used to die within 3 to 5 years were living and not dying. They were living 10, 20, 30. I have a woman out now about 25 years from the day we put her on Gleevec when it first came out. So that was a game changer. And since then, we found more game changers. In breast cancer, the HER2 new mutation is targeted. And again, you talk about targeted therapies in oncology these days. That target was targeted by a drug called Herceptin, dramatically changing people who would die no matter what kind of chemotherapy you gave them until you paired the chemotherapy with the drug Herceptin, a targeting agent. And I think that that's the paradigm. In lung cancer now, it's not enough to say small cell, non-small cell. We found out that non-small cell lung cancer had to be divided into squamous cell and adenocarcinomas. Well, that's not enough either, our scientists at the NCI told us, because these lung cancer cells can have targets on their backs. I call them bullseyes. They're genetic defects in their genome that can be measured today thanks to next generation sequencing. And so we could actually identify the target, take a drug that's available, and treat those patients with that targeting drug. There are probably 5 or 6 different targets that we can currently target, and there are innumerable other targets that have been discovered for which drugs are being developed and are currently in clinical trial. The problem is that these targets are rare as far as individuals with those specific targets. For example, one target called an NTRK mutation, NTRK fusion mutations, there are 3 of them, 1, 2, and 3, where you think that would be great. We'd have so many of them. Well, you don't. Only about 1% of cancer patients have one of those mutations. And it doesn't matter what the cancer is. It could be lung cancer, breast, ovarian, endometrial, you name it, that genetic defect has been described in it, but only 1% of the time. Sarcomas are another example. There's an 86% response rate when one targets that genetic defect with currently available drugs, all found through trials like this lung map trial, which I'm going to just review briefly in the interest of time. This is a major national study in the United States. The NCI is involved, SWOG is involved, and ECOG is the group we're involved with. Here, we register patients. You don't need to get too lost in all of the colorful boxes, but basically, we put people on it. They sign up, we do their genomics, and we see whether or not they have a target for which we can now give them a drug. This drug here is a new one. It's not on the market yet, but it targets the KRAS. Again, KRAS is a gene defect, KRAS G12C mutation. There are other drugs that target other mutations in this array of cancer patients who have these. And they get put onto the specific drug on this trial. It's an incredibly new way of doing things, because in the past, trials were open based on only disease site, not target. If you had breast cancer, you went on a breast cancer trial. Here, this rucaparib drug is used now on this trial in lung cancer patients, but it is also a key drug in ovarian cancer patients. Again, because the target can exist on various types of cancers, irrespective of where the organ that that it emanated from resides in that patient. So breast, lung, ovary, doesn't matter. And here is what we see. Patients who enter these trials will be divided based on their genomics to get the specific drug that targets their particular disease. So our study coordinators look at this and will help us identify patients. They enroll. If they have one of these targets, they get put into the trial. This is the target for G12C. And they will end up on this. This is Amgen. It's an Amgen experimental drug. AMG 510. We're looking forward to seeing that bring up some really good science data that will lead to its approval. Hopefully it will work. The majority of trials done, unfortunately, do not work, we have found. So in doing these trials with drugs like this, we have developed a wide array of drugs. We've been involved in these trials at the Cancer Center for 30 years. Drugs like Keytruda, which all of you unfortunately have seen commercials for on TV. It's a great drug. I'm not knocking the drug, I'm knocking the commercials. But that drug takes advantage of a different target. That's an immunotherapy drug. It stimulates the body's immune system to attack the specific target PD-L1 on the cancer center, on the cancer cells, excuse me. This drug has made a dramatic change in the paradigm for treating patients with lung cancer and a variety of other cancers. Almost every type of cancer now can be targeted with this drug one way or the other, either with a companion molecule or without it. In lung cancer, for example, if the tumor cells express a high concentration of PD-L1 positivity, 50% or higher, they can be treated simply with Keytruda or pembrolizumab, same name, the generic versus the trade name. That drug results in dramatic change in the life expectancy of lung cancer patients. If the patient has a lower level of PD-L1, generally we treat them with the same drug, but we do add chemotherapy to it. And even if they don't express that, the chemotherapy helps the drug work. So it's a partnering of standard chemotherapy plus immunotherapy that can reap great benefits for our cancer patients. I'm going to go through this in the interest of time. We alluded to earlier in the talk about our collaboration with the Dana-Farber Cancer Institute. This is a trial in CLL that we're involved with. Steve Lowe, one of my partners, is listed as one of the investigators here. And this is an interesting study. It's state of the art. People from around the country want to get on this study. And because of that, we've been able, through our collaboration with the Farber, have people coming from as far away as Delaware, New Jersey, upstate New York to enter this type of trial, which gives them access to this very new drug, acalabrutinib, which is administered orally. A lot of the targeting drugs are administered orally. The immunotherapy drugs, on the other hand, are administered intravenously. So this drug is an excellent example of collaboration amongst scientists. We've already had 2 patients put on this trial coming from as far away. You can see from Philadelphia, the first patient. We also have now updated this. I didn't get a chance to update the slides, but we now have 3 patients coming from elsewhere who wanted to enter this trial. In the trial, we're looking for minimal residual disease. That's undetectable disease, essentially. That is so rare in treating CLL patients that you never see it, except when you're using drugs like this. And that's what's so exciting about it. I think, again, in the interest of time, I'll move through that. This is an example of our clinical trials. We do trials in breast cancer. Again, some of these are cooperative groups. Some of them are industry trials. This is an immunotherapy trial in breast cancer. ECOG-ACRIN is one of our cooperative group trials, and these are 2 Farber trials that we do here. In colon cancer, we have this trial. It's an alliance trial, again, a cooperative group. We're looking not only for drugs that work in treating cancer, but drugs that decrease the toxicity of some of the older drugs, like this particular drug, oxaliplatin. Great drug, works well, but causes numbness and tingling in patients. If you use enough of it, everybody gets that, and it can be permanent. So this trial hopefully will show us a way to prevent the peripheral neuropathy. Moving along, this is the array of lung cancer trials. This is the lung map trial, which I briefly alluded to earlier. These trials now pretty much go along the lines of looking for targets, and it's so difficult to find the targets, the patients with those targets sometimes, but with enough centers doing the same trial, there's strength in numbers. I want to spend a little time, the remaining time, on screening. We have found an enormous number of new patients enter our practice over the past 3 months. A lot of that was because patients were putting off routine screening tests. Screening is dramatically important for all of us. Early screening it used to be limited to breast and cervical cancers. There was some data suggesting that PSAs for prostate cancers should be utilized. But most recently, right here, lung cancer. One of the leading causes of cancer death in the United States is lung cancer still. And lung cancer can be screened for. CT scans, and our group was involved in the clinical trial that showed this, and there were multiple trials done before and since. We can reduce death by screening prior heavy smokers or current heavy smokers with CT imaging. It's a low dose screening technique. It doesn't give you as much radiation as standard CT scans do. The study was done in patients between 55 and 77, clearly showed an advantage with an earlier diagnosis, which in lung cancer means lower stage, more curability. We now have increased that, and they're about to approve it. We now know that the data suggests that we should be screening people from 50 to 80, not just 55 to 77. Again, the original study was done in that first cohort. To get on the screening list, you have to have high-risk smoking history, 20-pack year or more. That means you smoke for 20 years, a pack a day, basically, or who are current smokers or smokers with that kind of pack year history who quit, within the past 15 years. We have to screen a significant number of people in order to get one positive, but it's definitively worthwhile doing. I can't emphasize this enough, and we should not be putting off our screening tests. Dermatology is another screen that we should be using. Melanoma is another disease that if you catch it early, it's a nothing. If you don't catch it early, it's a major, major catastrophe for that individual. Dermatologists are very skilled at doing total body skin checks, looking for early signs of malignant melanoma, and people have been putting that off as well due to COVID. And I must say that in my own experience at Stanford Hospital, in March and April of last year, I really thought I was on a MASH unit. We were seeing a dramatic change in the types of people we saw in the hematology arena. They were getting blood clots, pulmonary emboli. They were all in the ICU. As alluded to earlier, we had 3 different ICUs operating and 60 beds being used. Floors that used to have single occupancy, which is basically all our hospital beds and rooms. We had 2 patients in each room separated by a screen. Never did that before. It was dramatically different than anything I have experienced since coming to Stanford so many years ago. Today, it's not like that. We're not seeing the increased numbers of cancer-related COVID patients. We're not seeing an increased number of hospitalized patients so much as we did before, although we're seeing many more patients in the state and in the nation who test positive for COVID. It just seems to me that the mortality rate has come down significantly due to the excellent work done by our infectious disease colleagues. And so I'm very grateful to them. And hopefully all of you listening tonight have already had the vaccine or will go get it. I think I'll stop there because I'm over. And I think we're opening up to talk to some questions now.
Yes, thank you so much, Dr. Del Prete. Terrific. Well, I want to thank you all so very much for being here this evening, especially to our esteemed guests, Dr. Shaw, Dr. Falahi, Dr. Del Prete, Laura, to our host, the Darien Library. We are so fortunate to have Stanford Health and Stanford Hospital and these highly skilled healthcare professionals right here in our neighborhood. We hope tonight's program was informative and has encouraged you to get the health care you may have been delaying over the last year. So please make those appointments, get your vaccines. For anyone that couldn't stay on the program, this program will be available by recording on the Town of Darien's TV 79 on demand. So with that, again, thank you all so very much for all of your time this evening, for all the incredible work you've been doing over the past year, putting yourselves in harm's way with COVID. We're so grateful and thank you for being a partner to the Town of Darien. Have a good evening.